into that today because it will take time. But this is the most common single gene disorder, first recognized in 1925 by a Detroit physician, Thomas Cooley, who looked at these children. And as it was alluded in the previous talk, it's a highly heterogeneous disease. You have got different types of thalassemias: alpha, beta, delta, beta, gamma, delta, beta, and basically depending on which globin chain is reduced. And the main problem is the pathology is due to the imbalance of alpha and beta chain production. And when you have free globin chains in excess, they damage the red cell membrane, affecting the efficacy. Again, the genetics is very important. So it's just a genetic tree showing the heterozygous states. And you can see that there is 1 in 4 chance that it would be a normal child. And then you have a 1 in 2 chance to be a carrier, which is the heterozygous, and 1 in 4 chance. So it's an autosomal recessive pattern that you see in these patients. Interestingly, a lot of these hemoglobinopathies happen with the worldwide distribution of hemoglobin disorders, where it mirrors falciparum malaria. And you can see the different types of diseases which are tabulated here, including thalassemia, sickle cell anemia, HBC disease, HBD, and HBE disease. So it kind of mirrors that into the distribution of falciparum malaria. Briefly talking about alpha tal, there's reduced alpha globin chain. You've got the most serious forms which are restricting it in Southeast Asia and some Mediterranean islands. Both HbA and F have alpha chains. You've got the hemoglobin BATs, which causes hydrops fatalis, HbH disease, and then alpha trait. If you look at the alpha trait, you can have heterozygous states with 1 deletion of 1 alpha gene. They may have normal fill count film and slightly lower hemoglobin MCV or MCH. The homozygotes can be very similar to beta thalassemia traits. And there are some other heterozygous with non-constant, non-deletion and constant spread will have more marked anemia, which will be classified based on the genetic analysis. So how do you look for it? You look for low MCV without beta tal or delta beta tal or variant deficiencies in your differential. HPLC is usually normal, and the neonates will have 1 to 2% hemoglobin BATs. A definite diagnosis based on DNA analysis. You can have co-inheritance of beta tal with it, which could reduce the severity because the imbalance between the alpha and beta chains reduced as a result of that. When you go to alpha not trait, that's seen more in China, Southeast Asia, and Mediterranean. Again, a similar pattern, but they might have mild anemia or normal pattern, 5 to 10% BATs hemoglobin in neonates. And then it is suspected if you also suggestive indices, ethnic origin, normal A to ferritin and F. MCV less than 25 will suggest this pattern in that case. And you can consider DNA analysis. HbH disease is a more profound form. These beta tetramers, because there is an excess of beta chains in these patients, these are ineffective and unstable with membrane damage by oxidized beta chains, causing chronic hemolytic anemia. And clinically, they will present as a mild to moderate thalassemia intermedia. The hemoglobin can vary a lot as it is a heterogeneous disorder. MCV, MCH is markedly reduced. The film is very striking in these patients, and the HbH could be 2 to 40% on the HPLC with HB with 5% BATs. A2 is reduced usually, and the golf ball inclusions in HbH preps will be sometimes be seen. And again, milder if there is a coexisting beta tal trait. The hemoglobin BATs is these patients unfortunately die in utero. These are gamma tetramers, and they're unstable with hyperbolic oxygen dissociation curve because the HbF will control the amount of oxygen. HB Portland will keep them alive till the 3rd trimester. And then there are a variety of other disorders which can present in combination, which I will not go through. What about beta thalassemia trait? And this the opposite happens. You've got reduced rate of production of beta globin chains, but there is excess of alpha chains in these patients. And if you look at the beta thalassemia trait, you have a blood picture which will resemble like iron deficiency. These patients will have normal to an anisopoikilocytosis, some stippling, target cell, irregularly contracted cells. And then you have raised red blood cells with low MCV, MCH, total hemoglobin normal or slightly reduced. They can become anemic during stress and pregnancy, but the HbA2 is the catching point. Sometimes it is low as well, but most of the times it is slightly raised. It has got no clinical significance most of the time, apart from carrier state. The thalassemia intermedia, as it is alluded to, it's a diagnosis which is difficult to make. No absolute requirement for regular transfusion is needed sometimes, and the clinical and genetic pictures can be highly variable. You can have a homozygous or compound heterozygous for a beta chain mutation, and you can have a combined co-inherited ameliorating factor like hereditary persistent of hemoglobin Hep. A2 is likely higher than in trait, and HbF is raised, and all should be genotyped. There is another one called hemoglobin lipour, which is a delta beta fusion gene. In these patients, you should look out for pulmonary hypertension, extramedullary hematopoiesis, bone changes, endocrine and fertility, and leg ulcer. Similar to thalassemia major, some of these patients will end up needing all of these investigations. What is not clear when is to transfuse these children, when to chelate, and what is the role of splenectomy and transplantation in these kids. Beta thalassemia major is the main one. Severe anemia at the age of 1 to 2. Hemoglobin is usually 3 to 7. Highly abnormal blood film with pipe and hammer bodies, target cells, nucleated reds. You've got very abnormal indices. And if your child had splenectomy, then whole jolly bodies, targets, lymphocytosis, thrombocytosis is seen. And the clinical features are due to severe anemia, and the real issue is the bone marrow is trying to compensate, and then you can have extramedullary hematopoiesis in the causing splenomegaly, which can, on the other hand, cause cytopenias. And usually the diagnosis is made with the full buff count film, electrophoresis, isoelectric focusing, and HPLC. And then you have other investigations which can be done, including DNA analysis and a few other things to look for other abnormal hemoglobinopathy. This is just a hemoglobin electrophoresis. You're seeing the HbA bar here, and then you've got HbSC and other features. Briefly talking about screening in UK, it is primarily based on high prevalence area where there is a high population of Asian population, where universal testing with full blood count and HPLC is done, whereas low prevalence areas, the full blood count is done and then assessment of ethnicity is done. And postnatally, nearly all children get a dried blood spot heel prick test at 5 days. In the screening in pregnancy, that's usually done at the booking visit, which is around 12 weeks. And essentially, family origin is asked for, full blood count is done, and HPLC will be performed plus minus partner testing. And after that, counseling if it is a high-risk pregnancy. There is a CVS or pre-implantation diagnostic testing is done. Goal is to give the reproductive choice. Postnatally, newborn is done at 5 days, and midwife does it, and there is an analysis of dried blood spot and looking at other conditions like hypothyroidism, cystic fibrosis, thalassemia, sickle cell disease. All of that is covered in that test to cover that. This is just a testing algorithm based in the high prevalence area that we used in Yorkshire. There are areas in Yorkshire which are high prevalence areas, and essentially that is used in our obstetric clinics to identify families where partner testing is needing or we have to do DNA analysis. So nearly coming to the treatment part of the talk, the pathology of beta thalassemia trait. Alpha chain excess causes ineffective erythropoiesis and shortened red cell lifespan. This causes anemia. There is increased marrow stress that causes skeletal deformity. There's increased iron absorption and organ damage due to hepcidin pathway activation, protein malnutrition, and then there is overactive enlarged spleen. This is typical feature of thalassemia major with shortened stature and distorted limb growth due to premature closure epiphysis. And you can see the large liver and spleen being marked on this child. In terms of thalassemic faces, you can see the maxillary hypertrophy as well as abnormal dentition and frontal bossing due to expanded bone marrow. And this is the classical hair on end appearance, showing the widening of the diploid cavities by the marrow expansion. So the main treatment of beta thalassemia major is transfusion, and you want to maintain the hemoglobin to 120 grams per liter. We normally keep the pre-transfusion levels to 95 to 100 grams per liter. This is because this suppresses the marrow red cell production and prevents skeletal deformity and liver and spleen enlargement. 3 to 4 weekly transfusion from the first year of life. But the problem really with this approach is that every unit of red cell contains about 200 to 250 milligrams of iron, and the body has got no excretory mechanism for iron. So by the 10 to 12 years of age, there is severe iron overload, and patients get secondary hemochromatosis with gonadal failure, hypothalamic failure. Some children get diabetes, dilated cardiomyopathy, and heart failure and liver cirrhosis. The endocrine complications, there is multiple organs which are involved due to deposition of iron. The liver disease could be related to the transfusion-associated infections, but otherwise the ferritin would be raised and patient will get hepatic cirrhosis. And bones will be affected as well. There is lots of requirement to monitor the bones in these children. And overall, the fertility of the child may be affected as well. And there is multiple avenues that need to be looked at for a beta thalassemia major patients. Over time, psychosocial effects happen because it's a lifelong treatment. It's important to keep the child with a clinical psychologist and social worker. And because there's so many specialities involved, it is important of a multidisciplinary approach is important. There is a care network pathway in Yorkshire where all the patients are seen at least once a year at a specialist center. Because the prognosis has improved with iron chelation, the patients are living in the 4th and 5th decades, although some may have problems with iron. I've talked briefly about the genetic counseling. In some Greek Cyprus country, it's very, very good, and there is a dramatic fall in incidence. And there's 2 screenings we do here in UK, antenatal screening and neonatal screening. Now, talking about the consequence of chronic transfusions, you've got acute complications, alloimmunization, infection, psychological, and iron overload. Acute complications are of any acute transfusions, could be circulatory overload, allergic reactions, Crowley, hyperhemolysis syndrome, sepsis, multiple other things which can happen as acutely. But the other problem that we see in children is alloimmunizations. This happens if you keep on transfusing red cells. There is a very high risk of developing antibodies. And the way to prevent that is to do an extended red cell phenotype before the first transfusion. And what we do here is it needs to be at least Rh matched, Kel negative. And then immunogenicity, you can see of non-ABO compatibility, 50% get immunized to D, 5 with Kel, 1.6% with E. Then there's Duffy, C, and KID as well. And essentially, nearly a third or a quarter of patients will get some kind of alloimmunization. And thalassemia starting transfusion before the age of 3 is important. Infections, there is good evidence that there is decreased CD4-8 ratio in defective neutrophil chemotaxis. This leads to acute bacterial sepsis. Using desferoxamine increases the risk of Yersinia, which likes high iron, and that can lead to bacterial sepsis. Viral transmissions through multiple routes, through the transfusion route as well can happen. And there are other diseases which can happen due to if they have had splenectomy or Lyme-related infections. Then there are psychosocial issues that we see in these children, and that can develop over time as these kids grow. And particularly, this is difficult in adherence, which will happen over time. The one thing which has made the outcome better in these patients is iron overload. This is just a diagram of normal iron that is located in different parts of the body. essentially very little is absorbed from our gut, and majority of that is stored in different organs in the reticuloendothelial system or liver. And this is very well maintained, but normally, it's in simple words, 5 to 10 milligrams of iron is circulated around the body and getting out of the body. But in each unit of blood, there is about 200 milligrams of iron. So you can see that 60 kilogram thalassemic patient receiving 45 units of blood annually had usually have a transfusion iron load of 9 grams of iron per year. And then there is some more absorption of iron through the gut as well. So you really are talking about a large amount of iron going into the body. And repeated transfusions can see over a number of months will increase the iron in the body as well. And this is the kind of the pattern that I think I will skip this slide, but the main thing is that you get iron radicals, which actually causes the damage. These are the organs which can be affected: pituitary, heart, liver, pancreas, and gonade. This is secondary hemochromatosis. But what does iron chelation do? You can see different cohorts at different eras, and you can see that initially, if you follow the green curve, where there was no iron chelation, you can see that these patients tend to die. And over a number of years where the iron chelation has started to come up, the survival has improved tremendously with chelation. This is the cause of death in thalassemia. So 60.2% of the patients die of heart failure, and that is primarily due to iron overload. And then there is few infections, arrhythmias, and myocardial infarctions. How can you monitor? Ferritin is a very cheap method to do it, but it's an indirect measure and it can be raised in other conditions. But if you look at this nice graph from NAGM publication many years ago, you can see that if your ferritin level is on 33% of time occasions, it's more than 2,500 nanograms per mil, then you follow this yellow curve, which means very good. If you are 33 to 67% times above this level, then you follow the green curve. And if your majority of the time are above this level, then you tend to have excess mortality over time. Liver biopsy is the other way, but it is obviously invasive and it correlates very nicely with the total body iron. Can be done in some patients, and it is a linear curve. The thing that we've moved on to is MRI scans. These are non-invasive, but it is again an indirect measurement. And if you look at different conditions, it correlates very nicely with the R2 MRI. And essentially, you can see hereditary hemochromatosis, beta thalassemia with hemoglobin E trait, hepatitis, most of it with a reasonable confidence interval, you're able to assess that appropriately. If you look at the T2 star MRI, that correlates very nicely with the cardiac outcomes. And essentially, if you have got a very low T2 star level, then your cardiac function is poor, whereas high will have a normal function. In terms of the iron chelation, you need to target around 1,000 to 1,500 micrograms per liter. And then there is a role of splenectomy if patient is needing a large amount of red cells being transfused. These are the 3 drugs we use: desferoxamine, deferiprone, and deferricirox, which is also called Exjade. Desferoxamine is a pump, can be given subcutaneously, intravenously. These 2 are oral tablets. This causes neutropenia. Deferiprone, deferricirox can affect the renal and function and can cause gastrointestinal dysfunction as well. Then if we go to this slide, it is clearly showing that when patients are getting desferoxamine, during that time, the labile iron is suppressed very nicely. As soon as you stop it, the levels start to go up as well. Deferiprone, again, you see a similar peaks and troughs in labile iron. So I think it's quite important to say that continuous therapy is important in these patients. This is the pattern you see with the deferricirox, which is much better control in terms of you're not seeing those peaks and troughs. There is a cost attached to it, and because it is a continuous therapy, and this is just a kind of a total annual cost for somebody who's receiving Desferal. And essentially, you have got a cost of nearly around £4,680. If you use a Baxter balloon pump, it goes substantially high. Exjade cost is nearly double the amount of that money. If you look at the survival, you can see that patients who only manage 0 to 75 infusions in the year the prognosis was effective. If you were able to tolerate more desferoxamine, then essentially compliance becomes very, very important, and the outcomes are improved as a result of therapy. Are there other things that we have to look at? So bone marrow transplantations from a tissue-typed matched donor, usually a sibling, it's got a good 80% long-term survival. Some people, now are reporting up to 90 to 95%, and most are cured. Much less successful and higher mortality if the patient already has iron overload, which we see in elderly patients as well, with myelodysplasia and other conditions where the iron overload is a problem. There is concern over fertility with busulfan conditioning, and you can see that only 1 in 4 siblings with a match. So that is an option, but not feasible for everybody. There's just a publication out in NAGM just last week at ASH as well. It was presented. So this is gene therapy. So this is Betty Begler gene autotemcel gene therapy, and this is primarily using a lentiviral. They have been able to cause the production of an alternative hemoglobin, which raises the hemoglobin levels in majority of the patients. The phase 3 study, I think it will be approved for licensing in UK and US. I think still the problem is that despite all of this, there is transfusions are a major issue, but this is the reality as well. So I think it is, to conclude, it's a genetically and clinically variable condition. Main focus on good iron chelation to prevent cardiac damage and liver damage. I think gene therapy is on horizon and maybe the future for a lot of these kids. I will stop there.
Thank you, Dr. Talha. Any questions or any comments, please, from the audience or the panel?
Thank you very much for a very elaborate explanation of the disease. And I would just like to know that in your patients, is alloimmunization more common in non-transfusion dependent thalassemias or patients who are on regular blood transfusions?
Patients who are on regular transfusions, virtually a third or a quarter of these patients have developed antibodies. And this is true for thalassemic patients and sickle cell patients as well. And the National Blood Service here data suggests that if we use the extended red cell phenotyping right at the beginning, we're able to select the right products for these kids on majority of the cases. Because if you've got a transfusion program running, actually when these kids are going to come in. And we've got the National Blood Service here has got 65,000 units of red cells in stock every day. So essentially you are able to pick and choose which is the right one. In terms of the kids who don't need that frequent transfusions, who are not on the regular program, I think if they didn't have an extended red cell panels done, then they also get alloimmunized. But most of the kids now, there is a kind of a national pattern that we will do the extended red cell phenotyping right at the beginning for everyone. And that gets repeated every, I think, 3 to 6 months. There is a protocol in place.
Okay. And do you have any experience with the new drugs like luspatercept, which can increase the blood transfusion intervals?
Yes, so I think we have got a little experience with that. We had some trials which were running here. I must say the results are overall kind of, in some patients, yes, we have seen some benefit, but in some other patients we haven't. So I think it's a mixed story there.
Okay, thank you.
Thank you, Dr. Jovaria. Any more comments or questions, or we move on then? Thank you, Dr. Talha.
Thank you very much.
So now we move on to our next presentation. Before we do that, we would like to welcome Madam Yasmin Rashid, our Punjab Health Minister, who has joined us in the seminar. Thank you, Madam, for joining us. We would now be moving on with the next presentation. Professor Jovaria Mannan is presently working as the visiting pediatric consultant in Fatma Memorial Hospital. She has a vast experience of looking after thalasssemic children for the last 30 years and has been she's been the chairman Medical Advisory Board of Thalassemia Federation of Pakistan, as well as the senior advisor Thalassemia Prevention Program run by the government of Punjab. Madam has numerous national and international publications on the management of thalassemia in Pakistan. She would today be talking about the current facilities for diagnosis and treatment. So I would be handing the mic over to Madam now.
Thank you very much, Dr. Ayesha. The current let's, as far as the diagnosis and the management of thalassemia is concerned, we first have to look at the burden of disease in the country. When we
Dr. Ayesha, can you share the slides?
We are trying to. There's a bit of a technical issue, but we're getting on with it.
Okay. Okay, thank you. Next slide. The gene frequency in Pakistan for thalassemia is around 5 to 8%. And approximately looking at the population, it's 6,000 new cases which are diagnosed per year. One must not forget that this will not include all those cases who die before diagnosis in the periphery, at places where I will tell you later, the facilities for diagnosis are not available. As far as the spectrum of disease is concerned, we have different syndromes. We have thalassemia major, thalassemia intermediate. Then we do have double heterozygotes, which is Thal-S, Thal-D, Thal-E. But we also have cases of hemoglobin H disease, as the previous speaker mentioned, and there is an overlap of persistence of fetal hemoglobin. Current facilities in Pakistan are provided in the public sector through tertiary care hospitals, DHQs, and THQs. I will come to the detail later on. The private sector, mainly the facilities are provided by NGOs. Some of the facilities are also provided by private hospitals and private clinics, but they are very negligible. People who provide these facilities, they are pediatricians, they are general physicians, some of them are hematologists, and also some paramedics, because where doctors are not available, it's the paramedics who carry out the treatment of thalassemic patients. When we talk about facilities in the public sector, then there are many departments which cater for pediatric, for thalassemic patients, like pediatric units, because most of the patients, they report in pediatric age group. The emergency department, because when a patient who is an adult and is sick due to any complication, he reports to the emergency department and is catered therein. But unfortunate thing is that he's only kept there for like 12 hours or 14 hours and then sent home instead of referring him to a proper unit, because that doctor sitting in the emergency is not well versed with thalassemia. Surgical units help these patients because of splenectomy and also surgical problems. Medical units help us, those patients who develop other diseases, as well as they report with cardiac disease, because cardiac myopathy, as all we know, is the major cause of death in these patients. Next. In the private sectors, it is mainly the NGOs, non-governmental organizations, which are caring for thalassemia patients. And in this, I would like to inform you that we have Thalassemia Federation of Pakistan, which has registered number of NGOs 59. And the treatment facility in these 59 places is provided by 54 facilities, and 5 facilities out of 59, they only have awareness facilities, guidance facilities. As far as the registered facilities are concerned, we have 21 facilities in Punjab, 10 in KPK, 2 in AJK, and in Sindh we have 23 facilities. In Balochistan we have 3 facilities. So total number of registered patients with these 59 NGOs are 62,000, which is a lot less than the existing patients. Reason being that when I say non-registered facilities, this really means that Fatmid is registered with us, but all the branches of Fatmid will not be registered with Thalassemia Federation of Pakistan. Likewise, if you take Sundas in Lahore, if one facility is registered with Thalassemia Federation of Pakistan, 3 of their other facilities present in Lahore will not be registered. So that is why this number of 62,000 is not the actual number. Next slide. So what does Thalassemia Federation do? Thalassemia Federation has a lot on its shoulders, and the most important thing is that they are trying for many years to have proper legislation which can help us in the prevention of thalassemia, because the population of Pakistan is so large that it is difficult to treat the disease. It's much better to prevent it. And we can only do that if we go by a proper prevention program. In any case, since we have not yet succeeded to have a law passed, our job from the Federation is that we hold workshops for the capacity building of NGOs and doctors who are caring for thalassemia patients. We conduct seminars for awareness of public. We hold national annual conferences in which we bring all the NGOs together, share experiences, and also during that time, try to give them maximum information on the latest treatment and availability of facilities at various places. We celebrate the Thalassemia International Day, which is also mainly part of awareness. And in this, we highlight all those patients who keep their treatment well by keeping their iron overload in check, who continue to get educated, have jobs, and are useful members of the society. We, from the forum, also prepare guidelines of management in various spheres, like guidelines for chelation, guidelines for emergency treatment of patients, guidelines in blood transfusions, and we disseminate them through all the NGOs. The Federation also keeps a liaison with Thalassemia International Federation, which is one of its jobs. To improve the conditions of the NGOs in the country, we have devised a method in which we divide the NGOs into tiers, different tiers, and according to the function they perform. Like if they give blood transfusion services, then a doctor must be present, and they should be registered with the Provincial Healthcare Commission as well as Provincial Blood Transfusion Authority, and they must provide some awareness in the shape of leaflets, especially on chelation as well as prevention. And if somebody does addition to that, which is shown in this slide in the blue color, if that center also manages chelation, provides genetic counseling, and arranges for carrier screening or facilitate the prenatal diagnostic facilities, then we say he is in tier 2. And tier 3 is a place where only 7 of them fall in tier 1. In 21 are in tier 2, 16 are in tier 3. So then these 16 are the only one which you can say that are doing optimal things. And 10 of the NGOs, they don't even perform all the facilities which should be in tier 2, like as I earlier said, that the blood transfusion is being given because there is a paramedic available who is not well equipped with the blood transfusion reactions or other emergencies which can come across. They are 10 in number. Next. In this country, the diagnostic challenges have many gaps, because everywhere science is an ever evolving thing, and there are new things coming up. The introduction of Mahedol scoring to evaluate thalassemia, being mild, moderate, or severe, this is a very useful thing. And in Pakistan, I have a published paper in which I have used this scoring for the assessment of thalassemia grades. But most of the people who are looking after thalassemia are not well versed with it, and they don't use it. Then interpretation of hemoglobin electrophoresis. For the last 2 to 3 years, in every workshop and seminars, we insist that you should not just look at the electrophoresis and decide what will be your plan for the treatment. Actually, you have to look at the patient. And looking at the patient really involves most of the Mahedol scoring system. Because of this reason, the differentiation between transfusion-dependent thalassemia and non-transfusion-dependent thalassemia is not accurate, which is a challenge because in this country, it is hard to get blood, and that also safe blood. Components are not available. So it is very important that if we can save some patients from regular transfusions right from the start and see how long they can survive. The earlier speaker said that we can keep them blood transfusion free up to 3 to 5 years. But in Pakistan, I have patients whom I can manage in their up to 40s. They get married and have children. And I keep checking on their spleen every follow-up, and it is manageable. And that is why I asked that question. And I partly know the answer because I personally feel that when we are doing the thalassemia clinics, we have a lot of thalassemia intermedia patients. The reason being that I do not know how many transfusion-dependent thalassemias are lost before they reach me. Many of them, they are lost in the first year of life, because when they have an intercurrent infection and they report to a basic facility, they're extremely anemic. And in the time which is taken to get the blood and transfuse it, you mostly lose these patients with severe pneumonias, acute gastroenteritis, and sepsis. And of course, we don't have the luxury of availability of genetic diagnosis to decide whether this patient is thalassemia major or thalassemia intermediate. Next. When it comes to the management of thalassemia, the initial plan is very important, because number one, it tells you whether your patient should get regular blood transfusion or infrequent transfusions. And secondly, the complications of transfusion-dependent thalassemia and non-transfusion-dependent thalassemias are different. So when you're doing monitoring, you have to look into this, that which patient are you dealing and which complications you expect. Secondly, in management, since we do not have comprehensive health facilities which cater for thalassemia, it becomes very difficult for the patients to appreciate where they should be going. And many a times they are going to places where they are not properly looked after. Thalassemia, doing in Pakistan, thalassemia work is also not a work in which we have some criteria for promotions and going up. So most of the doctors, they do thalassemia for a few years and then leave it. So we don't have dedicated thalassemia clinicians. And to add to all this, the financial constraints, and at every health facility which is dealing with thalassemia, because as Dr. Talha said, that these things are expensive, the chelation therapy and the administration of blood. Next. The other challenges in Pakistan, many places we do not have the facility of blood components. So patients are transfused not red cell concentrates, but they are given whole blood. Second, safe blood is also not available in all the facilities. When it comes to chelation, there are three things which are very important, and that is availability of the drug, because many a times a drug which a patient is using becomes absent from the market. Affordability, because they are very expensive. Not all patients can buy it. So when a chelating agent is present in a health facility, in an NGO, if their finances finish, the drug doesn't come, and then there are gaps. And compliance, of course, is difficult, because that is true for all chronic diseases. Monitoring of these patients is very difficult, because there is lack of staff in the shape of doctors and paramedics who themselves are not well versed with the monitoring. When it comes to splenectomy, the proper decision when to perform a splenectomy, that is the first problem. Secondly, affordability, because now after some of the children hospitals which are specifically for pediatric age group, the general hospital surgeons have refused doing splenectomies for younger children, and they send them to children hospitals which are limited, so they have long waits. Transition from pediatrician to adult care is not present in Pakistan as yet. You can only use your personal contacts or your relationship with an adult clinician to take care of your adult patients. And clinical hematologists or pediatricians, they are not well versed with a lot of diseases which are adult diseases. There is also not the availability of specialized care, as Dr. Talha said, that this is a multidisciplinary approach or treatment. Absolutely correct. We don't have endocrinologists who are involved, orthopedic surgeons, cardiologists, gastroenterologists, and psychologists, which is also very, very important. We don't have proper therapists, physiotherapists, because these patients have a lot of orthopedic problems, which are due to disease as well as inappropriate chelation, vitamin D deficiency, hormonal deficiency, which is not in adult patients compensated because their endocrines have already been damaged. Emergency care is a very specialized field in thalassemia, in which at present the emergency staff is not familiar with. And of course, the bone marrow transplant units are limited. And the other problem is that Pakistan does not have a bone marrow registry. So if it's the first child or the only child, then the possibility of have a donor are extremely low. Next. Next slide, please. So to meet all these challenges, we have to increase training of doctors and paramedic staff at all levels. Next slide. And we must remember that prevention is also a very good option to reduce our challenges, in which Punjab Thalassemia Prevention Program has taken the lead and doing a lot of work. Next. This is the Punjab Thalassemia Prevention Project, in which you can see that in Lahore, there are 3 districts which are looked after: Multan 3, Bahawalpur 2, Rawalpindi 3, DG Khan 3, Faisalabad 3, Sahiwal, Gujranwala, and Sargodha. Next. CVS facilities are available in 21 facilities out of these 27 offices, which is commendable. And almost 100 to 120 CVSs are performed every month. In last year, more than 1100 CVS was performed. And since from 2012 to 2021, 6,600 CVSs were performed, out of which the number of patients who had thalassemia major were only 1,700. So that means at least we saved the country to a number of 1,700. And this can exponentially increase if we can continue to increase the awareness and the facilities further. Next. So we have to do a lot, in which National Registry of Thalassemics were started twice, but unfortunately has not yet been completed. We have to give trainings to THQs, RHCs, DHQs, and BHUs, because many patients who are thalassemics and they reach to these facilities, doctors which are fresh sitting over there, they are not familiar with thalassemia. We also have to address the general physicians who work very hard in the community and must be having a lot of patients. We have to improve our blood banking facilities to give safe blood. And also we have requested our worthy Minister Sahiba to make sure that all the private blood banks are also registered so that they are also up to the mark. Availability of drugs has to be ensured, in which again, government has to just see how well they can do it. We can increase the bone marrow transplant unit and the national registry. Thank you very much for your education.
Thank you, Dr. Jovaria. Any comments or questions before we move on to the next speaker? Thank you, Madam. Now we move on to our next speaker, who's Mr. Ahmer Bilal Sufi. He's Pakistan's former federal law minister and a founding president of Research Society of International Law. And he will be talking today about the legislation. So may I invite you to start your presentation, please? Mr. Ahmed Bilal Sufi. So Dr. Zeeshan, is he with us?
Yes, probably he was not having credentials to share. Now he can share his screen now.
Can you hear me now?
Sir, please share your screen now.
Yeah, can you hear me?
Yes, we can hear you.
Okay.
But we cannot see your slides if there are any.
Yeah, there are slides, but I think I can do without them because my team have passed on repairs, they haven't been received. So
sir, excuse me, sir. Sir, your sound is very distorted. I fear that people will not be able to understand that.
Can you hear me now? Is it better? The sound?
Not that much, sir.
Okay. Can you? I don't know. My team had set this up, so I am hoping that you should be able to hear me. But I think the microphone product can be. Yeah. Can you hear me now? Is this better?
Yes, this is better.
Yeah, this is better, sir. Thank you.
Okay. Bismillahirrahmanirrahim. Honorable Minister and very distinguished medical colleagues, doctors, professors. It's always an honor to participate and in such a gathering of very learned doctors. The subject which has been given to me is legislation relating to thalassemia patients. I only will have three major points to make. The first point is that we may not be able to have a federal legislation on the subject because of the limitation of 18th Amendment. Meaning, once you have the 18th Amendment, the subject of health has been devolved predominantly to the provincial governments, except those areas which are linked to some international convention. So if there is an international convention that creates an obligation relating to health, then legislation to that extent can be done by the federal government. And that appears to be the reason why the federal parliament has not been approved so far. We do have two provinces which have legislated, which make, which induce all the compulsory tests, and they are the province of Balochistan to assess the status and the post-implementation steps that the health department in both these provinces have undertaken to figure out if what has been the response of this legislative mandate. The response will determine if, let's say, the government of Punjab wishes to introduce a similar law, how should it proceed with the same? Or the government of KPK wishes to do the same, how should it proceed with the same? So the experience that the government of Balochistan and the government of Sindh may be sharing with the federal government and remaining two provinces will be instructive. The law does not have strong penal provisions, and the purpose seems to be just to encourage. Now, we also notice that there are some fundamental constitutional issues that come into play, and people are hesitant to undertake tests even when they are encouraged to do so. The previous speaker was talking about psychological counseling. That is one of the very prominent options. The other option is to make people better informed at all levels so that they are persuaded themselves to undertake these tests voluntarily. And that is the route which the WHO seems to prefer. The World Health Organization wishes to take the direction that let us encourage people and make them educated enough so that they are tempted to take those tests themselves. That is the approach of WHO. But the question is, can we force people or can we even induce them? The legal problem areas that need to be addressed would be the right of privacy that people insist have, and they argue that it is our choice, independent choices, whether we wish to undertake tests or not. As I said, in the context of information, we now have Article 25A of the Constitution, which talks about making education compulsory up to the age of 16, meaning that the syllabus that the schools are to be taught, in that syllabus, the information in respect of the utility of these advanced tests can be emphasized and put across through Article 25A mandate. The other legal provision that could be of assistance would be the right of information under Article 19. Now that right basically says you have the right to seek information, but once you mirror image that right, it also is associated with the right to yield information and spread information. Similarly, if one were to look at the right to life provision, which is Article 9 of the Constitution relating to security, in which want to get from the remaining provisions of the Constitution, such as you prevent and so on and so forth.
Sir, we can't hear you. There's a lot of disturbance in your audio.
I can stop it because I think it's a problem.
Sir, अभी भी आवाज साफ नहीं है.
Yeah, I can stop it.
Dr. Ayesha, probably we cannot hear Ahmed Bilal Saab's voice. So
ठीक है जी.
just skip this and move to the next speaker, please.
Okay, should we move on then?
Let us check the technical error there.
जी. Thank you, Mr. Ahmed Bilal Sufi Saab. Are you online, sir? Or
Thank you very much.
thank you, sir. Thank you very much. So we move on to our next speaker. It will, Madam Health Minister, thank you for joining us in this session. And so Dr. Yasmin Rashid, Professor of Obstetrics and Gynecology, has a long association with thalassemia, and will today be talking about as to her experience and her journey and the destination in regards to the thalassemia. Madam, may I invite you to please begin your talk. Madam, you're mute. We can't hear you. यहाँ से unmute करें, वो कह रहे हैं.
Can you hear me now?
जी, we can hear you now.
Just put on my presentation. Basically, I'm going to talk about the Punjab Thalassemia Prevention Program or the project, because it's basically my journey, is a part of my journey and the destination. 1994, when I started taking, I took a course in Leeds University to learn how to do prenatal diagnosis, and came to know that the most common problem that we would be facing in Pakistan was thalassemia. And when I came back, the first and foremost thing that I tried to do was to establish a prenatal diagnostic facility here. And I was very lucky that the Army Armed Forces Institute of Pathology had worked on developing one of their senior people who was already, I think, joined us, General Suhaib Ahmed, who had been trained in England, particularly to do the molecular biology work on it, while I would do the in 1994. And since 1994, from that time onwards, we learned how important it was to create awareness among people, because until and unless people were not aware about it, they would actually not come forward to have their prenatal diagnosis done. And prenatal diagnosis by itself was expensive. It was extremely important to advocate to the government how important it is that we pay attention to the prevention of birth of thalassemia in major children, because I think Dr. Jovaria has given you a lot of detail on how difficult it is to give the optimum treatment to thalassemia children in Pakistan. And we, of course, face the same problem in Punjab. Although I still feel many a times that we are far better off in Punjab as compared to other provinces, for a simple reason that the government at all levels is now actively involved not only in the prevention, but also involved where the treatment of children is concerned. So one of the most important thing was advocating to the government to ensure that they listen to what we had to say. And we went through difficult times. We even had to walk to the base camp of K2 with 5 thalassemic children to create world news of blood transfusion dependent children, walking to the base camp of the second highest peak in the world. Of course, it was breaking news. And that was the first time the government started paying attention, and it was 2001. And then gradually things start moving up. 2004, we got a little bit of ownership from the government. At least the government started listening to what we were saying. And the best day of my life was that after a long struggle, finally we broke through, and the Punjab Thalassemia Prevention Project was started. And I could go on to my first slide in 2009. Before we came on to 2009, let me tell you, it was a really hard uphill task for all of us, which myself, Dr. Jovaria, General Suhaib, we were all involved in trying to make the government aware how important it is that we start working for thalassemia prevention. But finally, we were lucky that the government paid heed to our demands. And the first thalassemia prevention project supported by the government started in 2009. In 2012, there were 4 divisional centers and 18 districts got involved. In 2016, we had 6 divisional centers and 28 districts involved. And in 2018, we had 9 divisional centers, and all 36 districts started providing free facilities with premarital carrier screening, extended carrier screening, genetic counseling, prenatal diagnosis, and also facilitation for termination of affected pregnancy where the parents wanted it. Next slide, please. If you look at it, this is just a project network. It's now considered to be one of, because of the large number of population involved. Punjab, if it had been a country, would have been the 13th largest country in the world, just on the basis of its population. So automatically what is seen is that this project has become huge just because of the number of people which are involved in it, the number of population. And if you look at it, now it is spread over all 36 districts in all the 9 divisions of Punjab, where what we are doing is we're giving facilities, which if I go on to my next slide, you will see. Our target was actually basically carrier identification. The World Health Organization has always believed that where the prevalence rate is less than 10, it would be good if we did targeted screening. So we started working on carrier identification and then prevention of thal major births. And how did we accomplish that? What we did was, number one, of course, create thalassemia awareness. And I assure you, we came a long way. I still remember when I first learned about the thalassemia problem in Pakistan myself in 94, 95, and I was trying to create awareness about it. It was difficult even for me to convince that the Minister of Health at that time to come and join us for a seminar, because he kept on telling me that the name is very difficult. And tried to memorize the name. Alhamdulillah, now I think we are very lucky that the large majority in Pakistan are aware that thalassemia is a common genetic disorder and it is a problem. The next thing that we did was we believed that we have to do extended family screening. And how did we accomplish that? Every thal major child being diagnosed in whichever family, what we ensured was that their family, extended family, was screened so that we could pick up a maximum number of carriers. And it has been seen that in extended family screening, where there's already a child who's been affected, you normally have about 33% of carriers coming up. And then, of course, offering them prenatal diagnosis in case they were married and they were already having, two carriers were married and were having a family. We worked on prenatal diagnosis. On the other hand, genetic counseling was taken up to ensure that the people who are not married, you do understand there's a lot of consanguineous marriages in our family, in our country. So we try to convince people that it will be better if they don't get married off two carriers. But if two carriers do need to get married, then prenatal diagnosis services are being provided free of cost by the government, and it would be good if they have the prenatal diagnosis done. And it would be, and I think one of my best possible days was, this happened even before we started this program. I think I should quote, it was about 2006 or 7, when we had already created quite a bit of awareness about thalassemia, that I got my first patient who didn't have a thal major child, but had come in because her sister-in-law and her own brother had a thal major child. So she came to me for screening. And the first 3 screening that we, prenatal diagnosis that we did, turned out to be the babies with thal major. She went on for the termination of those pregnancies. And then finally, she has now 3 more children who are, 1 is a carrier and 2 are absolutely normal. Of course, genetic counseling is a very, very important part of our strategy. We had to ensure that our field officers who go there understand the importance of genetic counseling, and they know how to do group counseling. And we have recently developed, I think, with the collaboration of Leeds University, a remarkable tool to counsel families, how to make them really understand the problem of thalassemia and how does it affect the whole family. Can I go on to the next slide? If you see the next slide, this is a sort of, when we started off, it was one, of course, large center which we have, which of course has a lab. It has a DNA lab, and majority of the samples come back to us regarding screening and confirming if the person is a thalassemia carrier. And of course, we are doing all the prenatal diagnostic test results also here at the same lab, which is now housed in Fatima Jinnah Medical College University and is providing these facilities. Of course, the regional offices in all 3 9 divisions, and then at the district headquarter hospital. And normally what we have, the district headquarter hospital has field officers which have been trained to go and collect samples for the target screening, have them analyzed, take back the results to the family, and then counsel them. Next. So basically, if you look at it, we do genetic counseling, blood collection, then carrier testing. And once we have managed to create awareness about it, then we are also ready to do the chorionic villus sampling and result feedback. Next, please. Next. Over the last, if you look at the time from 2012 to 2021, an extended screening of more than 9,970 families have been done, which means every child, at least 9,970 children who were identified with thal major had their whole family screened. We have to, from 2009 in 2019 and 20, if you look at it, we were doing very well till 2018 to 19, but we faced a setback in the year 19, 20, and 20, beginning of, 20 and 21, because of the COVID problem. With the COVID pandemic, our work definitely slowed down. It was really not possible for us to continue at the same, I think, strength that we were going on previously, and therefore the number of cases definitely reduced. Alhamdulillah, now we are in a much better position, and hopefully this year we should be improving the numbers of families which are going to be screened. So if you look at it, there were about 210,698 individuals which have been screened now. That is a huge number. And that is why it's considered to be one of the largest programs. And hopefully, inshallah, once we continue it, I think in another next couple of years, I think we would be well involved with every Thalassemia child which has been identified, and families belonging and individuals belonging to the family would be screened, inshallah. Next. So if you look at it, it is considered to be one of the largest screening work in Pakistan. And the good part is we are doing early identification of young carriers. Now, 70% of the carriers that we have identified are between the age of 5 to 25 years. As they come into a marrying age, naturally, since everybody knows now in their family, and we start counseling their family, they can also go through this whole counseling process. And then they can make informed choices, whether they like to marry into the family, to another carrier. And if they do decide to get married to a carrier, how would they think about planning out their families, particularly their prenatal diagnosis? Next. Next, please. We have already given prenatal diagnosis to more than 6,629 couples. This is basically the center that is running. I have not added those numbers, which General Suhaib Sahab is also working on. So I'm sure he must be giving you a big number also. So we are constantly working on it, and you've seen that the number of cases have gone remarkably up. It's except for this year, when we, as I said, we faced a big setback because of pandemic, of the COVID pandemic. Next, please. And of course, the results of the prenatal diagnosis was these people going in for majority of them. There were hardly anyone who did not opt for a termination of pregnancy, and we went through 1,698 effective pregnancies being terminated. The good part is that since it has been a combined effort and part of quite a few individuals of us working together, we were very lucky that right in the beginning, when we started working on prenatal diagnosis, General Suhaib, along with General Salim, who was at that time looking after the Armed Forces Institute of Pathology and was a hematologist, ensured that we don't face any problem, particularly any religious stigma coming in, and they took fatwas on it. And to date now, I think there are more than 14 fatwas from various different countries, which actually ensure that the soul comes into the body at 120 days, and we manage to do diagnosis before the time. Termination of that pregnancy would not be considered as a sin, and therefore, when we do counsel our families, they are made to understand about the religious involvement in it also, so that it can help them make a choice. Next, please. We've already told you the number that has gone through genetic counseling. So there's nearly been 178,663 people who've gone through genetic counseling. Next, please. So basically, I've given you an idea about what all we have done to date. And I think it has been a long journey, but then a journey like this, which has produced some good results for us, that we have managed to now set up a system which is totally supported by the government. And the good part is now, which I think this is a news which needs to be shared with Professor Jovaria Mannan, because she is the one who really looks after the treatment, is that all Thalassemia families are going to get their health cards, so that now their children treatment, basically many of them used to suffer because they never had enough money to have their children treated, particularly ventilation and everything was concerned. Now we'll have the support of the government through the insurance scheme to ensure that the children have proper treatment and they're looked after properly. And along with that, of course, we've already told you that we're expanding our program now that we have all centers now based in it. Now we're trying to develop the diagnostic services in the major regions, particularly in the south of Punjab, because it has been seen that the most common areas that you see more patients with Tal Major are Dera Ghazi Khan, then Rahim Yar Khan, Multan. Wherever there are a large number of Baloch population, they always show a larger incidence of, because it's considered, it is thought about it, the Baloch tribe, people who are from the Baloch origin have largest number of thalassemia carriers. So working on this, we are at the moment hopeful that inshallah we will keep on expanding this program of ours so that we can help all these thalassemic families, not only in looking after the treatment of the children, but giving them the facility of prenatal diagnosis. And we hope that other provinces also follow this, because until and unless the government supports your prenatal diagnostic program and your, it would not really be possible for any NGO to really look after all your thalassemia people who come to you for prenatal diagnosis. Prenatal diagnosis is an expensive test. So it's been a long journey, but end of the day, it's quite soul satisfying that though it was nearly a journey of 28 years, but Alhamdulillah, we managed to accomplish what we really wanted to do, is set up a major thalassemia prevention program in Punjab, being supported by the government, because that is the only way we can help in reducing the birth of more Thal major children. Dr. Jovaria has also given you a number. I've given you the number of children where the parents went through having the pregnancy terminated. So we are I think we are now in a good position to ensure that this program is expanded further, and hopefully we're trying to divide Punjab into 4 regions and ensure that there is a DNA lab provided in all the 4 regions so that the diagnostic ability increases and more tests could be analyzed and we can give more information to the families. Thank you very much.
Thank you, ma'am, for giving us the long history of thalassemia and thalassemic children being looked after in Pakistan. Any comments or any questions that the audience would like to ask?
Ayesha, I just have to ask the question. That Project ECHO has been used for a hepatitis program in Punjab. In the previous speaker, Ma'am Jovaria did said that we do suffer in the deficiency in teaching and training of the healthcare workers. So can we use this technology of virtual training of our different setups in the primary care as well as in the secondary care DHQs while using the resources of the faculty there, and this Zoom training forum and using the case-based presentations to teach our new doctors as well as the healthcare workers for the transfusions and its risk and the thalassemia training?
Number one, I'm sure Jovaria can give you her answer also, but I think one of the, both myself and Jovaria also work with the Thalassemia Federation. I'm working as its General Secretary and she is the Chief Medical Advisor on it. We do try our level best to conduct workshops, but I assure you, Dr. Zeeshan, I think it will be very good if we can take help through this technology and everybody's help in training more and more people, because we do understand that dealing and managing Thal major children is a totally different ball game. It isn't like dealing with any other child. Now that we have, you do know that the We have made a child health university in Punjab. The children's hospital has been upgraded to a child health university. And the purpose of child health university is basically to ensure two things. Number one, indigenous research, because we are very keen to have indigenous research related to our problems in Pakistan and in Punjab particularly. And the second is training people, because we believe pediatric work is a total different universe as compared to normal. After children with Thal major, and then as Jovaria said, it's extremely important that adults now, because with better treatment, the children are now becoming adults, they are getting married, they have their own problems and complications. So we need to now train physicians and people who have to look after this these adults now. And I think so we need not only training where pediatricians and related services are concerned, we'll also be needing help in training people who are going to look after the adults.
Now that I know that Dr. Yasmin knows all about it, but I also take the opportunity of sir sitting here. I think it is time that at least the tertiary care hospitals should have, every tertiary care hospital should have a thalassemia unit. And in that unit, at least I can train the doctors who are working there, and then they can train on further. Because right now what happens is that even the tertiary care hospitals, they don't take thalassemia patients readily. The minute there is a thalassemia patient in the emergency, they give Dacloran, this, that, and then they send that patient to Sundas or Gangaram Children Thalassemia Center or Fatmeed, which is not right, because those patients who come to the emergency department are serious patients. They need a multidisciplinary approach of all the consultants. So somebody, a doctor sitting in Sundas or Fatmeed cannot help that patient. So I think it has to start from the top and then trickle on.
I would agree.
Dr. Sabar, we have already, excuse me, I'd just like to reply to Dr. Jovaria. We have, as you said, we already require, of course, there's absolutely no doubt that every hospital should have a unit to cater for Thal major children. We've already started working on it. There's a unit which has been developed in Rawalpindi. All universities have been asked to ensure that they have a proper unit running to look after the thalassemia major children. They have set up a unit just last year, which I went and inaugurated also, regarding management of children in Holy Family Hospital. I totally believe what you were saying, that they require a multidisciplinary approach. So having a unit in a hospital will definitely benefit them. And we have already notified that there should be 10 beds assigned for thalassemia major treatment in all our district headquarter hospitals. And
looks like there is some technical problem. It's back, I think so.
I think we got to cut off, but anyway, we are, आपकी suggestion है बिल्कुल सही है, उस suggestion पे we already working on it, and inshallah, hopefully, by next year, we're trying our level best. There should be a unit in every hospital. Of course, there's a pediatric unit in every major teaching hospital, and they should start looking after Thal major children also, and they require treatment. And I totally believe what you say. Naturally, until unless we do it in such a wide spread manner, we would not be able to offer proper services to children with thalassemia major.
Madam, we have our VC, Professor Dr. Khalid Masood Gondal, who has joined us and would like to ask a question.
Comment. I think this is sort of comment. I take this opportunity to thank the Honorable Minister. I witnessed this program when I was the Vice Chancellor of Fatma Zahra Medical University, then at King Edward Medical University. And I personally feel this is a great Sadaqah-e-Jariya or इंसानियत की खिदमत का, this is one of the best example to be followed. और मैडम का I'm also grateful कि जितने भी कैमका यूके के हमारे जॉइंट सेमिनार्स हुए हैं, this is the fourth one on health reform, and madam remained available on all the seminar and she was the guest speaker. और इस थैलेसीमिया प्रोग्राम में जिस अंदाज में अवेयरनेस है, प्रिवेंशन है, काउंसलिंग है, एंड देन द ट्रीटमेंट, एंड आई पर्सनली फील जोवेरिया मनान की जो राय है प्रोफेसर साहब है कि वो बिल्कुल ठीक है, और मैडम ने इस पे वे फॉरवर्ड भी बता दिया, जो यूनिवर्सिटीज हैं अगर ये न्यू सब स्पेशलिटी क्रिएट कर सकती हैं, why not to create the consultant or the assistant professor post to look after these units, maybe on the pediatric side or on the hematological side, whatsoever is the. And then Professor Dr. Yasmin Rashid, ever since she took over as the health minister, I think there is so many reforms on the health sector. I happened to go into Dubai Expo, and our health card for the universal cover is a new example, probably first time in the history of the province of Punjab or maybe in the Pakistan. Similarly, PKLI services, and we had got the good experience of innovation of teleconsultation. तो मेरा अपना ख्याल ये है कि जिस अंदाज में अतरा मसीद और ताबिंदा ये सेमिनार करवाते हैं, उसका ये फायदा इस अंदाज में होता है कि there are some guidelines which are being set, or then we get motivated and inspired. और हर साल there are new things which are included in these seminar. So thank you Atar and Tabinda too, and thank you Honorable Minister for available, I think, in all the seminar, and whenever FJ King Edward or anywhere invited the Honorable Minister, she was there. एक दिन अटक में, एक दिन रहीम जार खान में, एक दिन DG मैडम.
Thank you very much.
Madam, we have Dr. Zahid Kamal who would like to.
Thank you, madam. When I was principal at Saiwal Medical College, then we sent you a request that we want to establish a center, and it was amazing that within a couple of weeks, we just provided some basic logistics and everything, equipment, staff, and everything was there. और वहाँ के लोग आपको दुआएं देते हैं. लेडी डॉक्टर्स की ट्रेनिंग भी वहाँ पे हो रही है, और अल्हम्दुलिल्लाह स्क्रीनिंग भी वहाँ पे हो रही है. And we have witnessed, because मेरी ट्रेनिंग भी गंगाराम हॉस्पिटल में हुई थी as ट्रेनी रजिस्ट्रार, so I have witnessed you developing this program. और जो आपने मल्टी डिसिप्लिनरी अप्रोच का बताया है, now माशाल्लाह we have 35 years of age, and some of them they are coming to me for their eye checkup, and for regarding the multidisciplinary approach, they develop refractive error, presbyopia at a very early stage. So we are looking after it.
Thank you to join another session for joining us. We move on with our next speaker. As you know that Mr. Ahmer Bilal Sufi Saab was interrupted with the presentation. So we go back to his presentation again. Mr. Ahmer Bilal Sufi, are you online?
Ji, I am online.
Ji. We can hear you loud and clear now.
Okay, that's very assuring. First of all, my apologies for a little technical hiccup. But anyhow, first of all, let me again thank all of you for allowing me this opportunity to talk about legal aspects of the test relating to thalassemia, and what kind of legislation one needs to have, and what kind of legislation already exists in our country. There are, as you know, the federal government made an effort to table a bill in federal parliament in 2017 whereby there was an inducement to recommend very relating to thalassemia. However, the bill did not primarily because of the 18th Amendment, I guess, consequence of delegating all health matters and executive action as well as legislative action to the provincial governments. So I believe pursuant to that, the province of Balochistan and the province of Sindh have made two separate enactments. One was done in 2014 by the government of Sindh, Balochistan. Laws seem to be reasonably identical. They do create a kind of an obligation. The reason I use the word kind of an obligation because the title of the provision, let's say in the Balochistan law says compulsory testing. But when you read the text and the language of the provision, it says you should. So should legal standpoint, and it is viewed as recommendatory and strongly recommendatory in nature. But having said that, the very fact that there is a legislation and there is a piece of legislation which is passed as a provincial law in two provinces is a very powerful milestone in terms of inducing the citizens and promising them and making them realize as to why this is so important and why this should be considered by everyone who's getting married, and especially those who. So what by both provinces only see establishment of a thalassemia board and not of a foundation, but not of a board. It will be very instructive exercise to take a review of as to what exactly has been a development post enactment in terms of compliance of these laws. And for that, one will need to refer basically to the provincial government's health ministries and ask them specifically about the nature of compliances and the way the centers have been designated. Have they become operational? To what extent people have been complying and how that compliance has been proceeding further? Is there a documentation of the said compliance by both the provincial governments? And what is the general trends of compliance? Is there a reluctance? Is there a follow-up by the provincial government administrative bodies or no? And so on and so forth. So that will make us realize if the legislation is sending the right kind of message in terms of its implementation or not. The other aspect, I think, based on this assessment or the review of the implementation, one may be feeling compelled to also insist upon the government of Punjab and the government of KPK and the government of AJNK. Whosoever is showing this this presentation of mine can kind of disregard it. I'm kind of narrating this, so you can dispense with it and let me. So coming back to what I was saying, so Punjab, KPK, AJNK, and Gilgit-Baltistan, the ministries can take advantage of the existing legislation, consider incorporating requests for compulsory legislation in the delegated legislation. Delegated legislation means rules, regulations that are made pursuant to the act. So if there is a health act, which there are quite a few, so one can develop rules pursuant to those acts, encouraging people to voluntarily come forward and undertake the testing process. That's one approach. The other approach is numerous medical institutions are creation of provincial legislation. So there are medical institutions and medical institutes and hospitals that are creation of provincial laws. Pursuant to those enactments, one can make legislation specific to that particular hospital or that particular institute, whereby patients or people who are registering, coming in and out, indoor and outdoor, they could be suggested to undertake these tests. So it could be starting from implementing measure point of view from a selective institution where the focus is more, and then it can grow at a provincial level and then finally translate itself in a provincial mode. The approach that has been developed by WHO is not insistence for a compulsory testing, but rather they are suggesting through their material, through their guidelines and through their literature that there should be an effort made to encourage people to be better informed. So the governments have the duty to inform the ordinary citizen in respect of his, so that he should be better aware and feel himself voluntarily compelled and insufficiently induced to go up to a testing center and say, well, I would like to test for the reason to avoid any future agony to my own family and so on and so forth. That would be the best case scenario. And for that, the legal obligation or the legal constitutional space is available in Article 25A of the Constitution, which talks about making education compulsory up to age of 16, which basically means you can incorporate the message relating to thalassemia across the country, and this would be just the right age to synthesize the youngsters, young girls and young boys about the significance of the issue. In addition to that, we also have Article 19 of the Constitution, which talks about right of information. And right of information is viewed not merely a right in which information should be given by upon request, but also relevant information relating to public health ought to be volunteered to the people and to the citizens. That is also an obligation on the part of the state. They must inform the citizens and the society as to what are the likely hazards in the issues that they are handling. So Article 19 and Article, as I said, 25A are important from the standpoint of ensuring a compulsion on the part of the provincial governments and the governments to push for more and more informed information relating to this area. In addition to that, if there is a case for a possible federal legislation, that can only come about if we are able to link this obligation to some international treaty or convention. In the 18th Amendment, there is one provision which says that those subjects in respect to which there is a bilateral or a multilateral commitment under a treaty, for them, federal legislation can be done. So that will be a very helpful route to take in the event that the federal ministry wishes to take up this issue. Even if the federal ministry, by virtue of 18th Amendment, feel hesitant, the Ministry for Interprovincial Coordination has a general mandate to help coordinate all legislation that is of interest in public health area. So I believe the Ministry of IPC can also play a dominant role in terms of legislation, in terms of encouraging it. We do have a multilateral treaty called ICCPR, International Covenant on Economic and Social Rights, and International Covenant on Political Rights, which creates the right of health as a matter of obligation. The areas of hesitation for such a legislation that I foresee are the Islamic view on that, and secondly, the right of privacy that has been guaranteed, that some people can view this as interrupting that right or interference in those rights. But for that, the way forward again should be that one could refer the proposition to the Islamic Ideology Council, which I believe is set up under Article 228 of the Constitution, for them to look into that. But as of now, not to my knowledge, there hasn't been a very strong opposition to the two enactments that have been passed in Balochistan and since as of now. So I'll just stop here, and if there are questions that I can take up to explain my views further, it will be a pleasure.
Thank you, sir. Any questions or comments that anybody would like to say or share? Okay, I think we are good for now. Thank you very much, sir, for your presentation. And now we would be concluding our session. Thank you all the participants and everybody. Thank you, Bilkis. And so for now, we're going to take a prayer.